Good morning, everybody.
Good morning.
Good morning.
Good morning.
Good morning.
Morning.
Good morning.
Good morning.
Good morning.
Morning, everyone. I think we still have a few more students to come in. But if you have not met me or have not encountered me, I am Ms. Green, and I will be lecturing on infection today. This should be for sections, well, groups 1, 2, and 5, group A. So if you are not in 1, 2, or 5 and or group A, then you should not be in this lecture and probably in the other lecture with group B. And Mr. Keller has some stuff to go over. So he will talk to you guys about that in a second.
Hey, guys, I'm kind of waiting for, us to get up to full capacity here. But we're in week 3. Next week's your first exam, right? So next Thursday. Tomorrow you have your test to learn the functionality of ExamSoft, okay? So tomorrow, if you haven't registered for ExamSoft, you have to get registered because tomorrow is the test run for y'all to learn how to use ExamSoft, okay? So when y'all are looking at ExamSoft, the questions are not nursing questions. They're just questions that are there to show you how to use the different functions like the calculator, the notebook, the notepad, how to make the pictures bigger, because you're going to need to know all of that. So make sure when y'all are in there, you got 10 minutes to learn the functionality. Learn how to use all of the things, because when the test comes next Thursday and you say you can't blow up a picture, you needed to see it, and you didn't take the time to learn how to do it, then that's going to be a problem, okay? So make sure y'all use all the functionality and you've got things that y'all know how to use the software before the exam, okay? That's next Thursday. Y'all are going to have next generation questions on this. That's what NCLEX has gone to. So there's going to be drop-down menus. There's going to be moving things around to place them in order. It doesn't change the way the answers are. It's just different formats. So I'm not sure if y'all are going to see the format changes in this new, in the little test y'all are going to do tomorrow. But on the test Thursday, you will have 4 questions with the new next generation format that's out there. So be tuned in for that, because that some of y'all are going to be taking next generation questions when y'all take NCLEX. So we're starting to teach you how to use those different formats, okay? And then finally, I want to reiterate, we're in week 3, okay? So this, y'all should be kind of calmed down and y'all should be getting used to everything. But these instructions are very important. You have to mute your microphone, right? Your camera has to be active. I don't want to see blank screens. I need to see your face. So I don't want to see the top of your head or the lampshade on the side of your desk. I want to see your face. So you have to be in the middle of the screen, all right? I'm going to chat you if you are not. I'm going to say, turn your camera on. I'm going to say, put the camera so that you're in the middle of the screen. The other thing is some of y'all have big windows in the back or doors. I can't see your face. I just see the door because it's so bright. I'm going to chat you. You know, you got to move your camera away from that back light, okay, so we can see your face. Y'all need to be dressed like you would be in school, not in your pajamas. You can't be in your pajamas, okay? You need to be dressed in proper attire. And you need to be like you're in school, sitting at a desk, sitting at a table, sitting somewhere where you can write notes, not lying on a bed or sitting on a couch with the phone up at the side or something. You need to be attentive. So if I'm going to chat you, you need to be looking at those things. Okay? That's just etiquette. That's what we're expecting. You're in nursing school, so we expect you to act professionally. Finally, the last thing I want to talk about is the chat box. Chat boxes are for instructors to talk to the students, not for students to talk to other students. okay? So if you want to talk to another student, you can text them, you can do whatever you want. The chat box is not designed for a student to answer another student's question or to carry on a conversation. So first 2 weeks, we've had issues with that. We've had issues where we get conversations going from students, we get things going on. If you've got a question, put it in the chat box. We will then answer in the chat box. And we don't need good morning, everybody, in the chat box. We know everybody's having a good morning. We don't need 50 good mornings. We got 150 students in this class, okay? So let's try to follow some classroom decorum, some etiquette, professional behaviors. If you have any questions or concerns that you need to talk to me about, I'll be glad to talk to you, okay? But remember, Team 1's concerns should go to the instructors on Team 1. So Miss Smetana, Miss Deep, Miss Dufresne, Team 1. If Team 2 has issues, they should talk to me or to Miss Chairs. If Team 5 has issues, they should be talking to Miss Green and Miss Strength, okay? So go to your team leaders, your full-time faculty, and express your concerns to them, okay? But Team 2 can come to me, Team 5 can go to their instructors, and Team 1 should go to their instructors. Okay, I think that's it for me. Miss Green, ready to go.
All right, you guys. So as I've stated, this is the concept of infection, and we will begin. So as I've stated, I am, oh, my screen is not, okay, there we go. So the concept of infection, you are, the SLOs, you should have read that. It is posted in Canvas as well as the outline. If you have not gotten the outline, please review the outline. Everything that is on the outline is testable material. So just make sure that you review the SLOs as well as anything that is in the outline. So infection terms. Infection is the growth of a microorganism in the body tissue where they are usually not found, typically called an infectious agent. And the disease, a detectable alteration in a normal tissue function. Virulence is a microorganism's ability to produce disease, and pathogenicity, the ability to produce disease. All right, and so an example of this would be HIV. However, so as I've stated, the infection is the growth of a microorganism. If there's no clinical evidence of the disease, it is called subclinical or asymptomatic. So an example of a subclinical or asymptomatic disease would be HIV. If there is no viral load in a positive HIV patient, then that means that their disease is subclinical. There's no detectable viral load in this patient. However, if there's a viral load that is detected, then that means the disease can be transmitted from person to person. So just remember that there's a viral load, and that means that the disease can be transmitted. If there is no viral load, then that means that the disease cannot be transmitted from person to person. All right, so types of infection. You have colonizations, local infections, systemic infections such as bacteremia or septicemia, acute infections, chronic infections, and nosocomial infections such as healthcare associated infections. There can be endogenous or exogenous. Colonizations are strands of microorganisms that become resident flora, which is microorganisms that occupy a particular body site and outnumber the person's own cells. Example of that would be E. coli or staph infection, such as cellulitis on the skin. So that would be an example of a colonization. Colonizers typically do not cause the disease. Should there be a break in the body's defense mechanism, the colonizers can invade and infect that site. So as I've stated, staph, it typically is on the skin. It typically does not infect us until there's a break in the skin where that staph is, and then you can have a cellulitis or a local infection. So a local infection is limited to a specific part of the body. If the infection spread, it is now considered systemic infection. Bacteremia is when the blood has microorganisms found in it. Bacteremia can progress to a systemic infection, which is called septicemia. An acute infection appears suddenly, such as bronchitis, the flu, or pneumonia. And then chronic infections typically occur slowly over time, such as tuberculosis. Nosocomial infections originate in a hospital. You have endogenous, which originate from the patients, or exogenous, which originates from the hospital's environment and personnel. The CDC reports that 2 out of 3 healthcare-associated infections are central IV-associated bloodstream infections, CAUTI or catheter-associated UTI, or ventilator-associated pneumonia. Any questions so far? Anybody have any questions so far? All right.
I have a
So,
question, if you don't mind. You were saying the viral load.
yes, in HIV patients.
In HIV patients, basically, if you don't have a viral load, you cannot get a disease. It's not detectable. I'm sorry. I just want to clarify it.
Right. So if the viral load is at 0, then it is thought that you cannot transmit the HIV disease to another person, which is why when you have an HIV infected person, it is encouraged that they take their medications and they check the viral load to ensure that the viral load is 0. So if you don't have any disease in your body, quote unquote, to transmit that disease to another person, then they can't get it. Which is why, but if you go without the medications, your viral load increases, and now you can transmit that disease to another person.
Okay. Thank you very much, Ms. Green.
You're welcome. All right, so healthcare associated infections. All right, you have, oh wait, go back. Hold up. What is going on with this screen? 1 second. All right, so you have ventilator-associated pneumonia, as I stated, C. diff, catheter-associated urinary tract infection, surgical site infection, and central line-associated bloodstream infection. These are all associated in the hospital. So if you are in the hospital, there's a chance that if you are on a ventilator, you can get pneumonia. If you're in the hospital, there's a chance, if you're not washing your hands, that one nurse can transmit C. diff from one patient to another patient. If you were in the hospital, you can get a catheter-associated UTI, which is leaving the catheter in too long or not properly cleaning the patient. And then the surgical site infection, again, if you have not, you should do your sterile dressing change. So if you don't properly change your dressing, then you can cause that patient to get a surgical site infection. And then central line associated bloodstream infection. This is basically when there's a central line that is not properly cleaned. This is a sterile dressing change, and you should follow the proper protocol to change the dressing. So there are 1.7 million patients per year that obtain a healthcare associated infection. And out of that, 90,000 of those are deaths. 28 to 33 billion in healthcare costs per year. So that is a lot of money of healthcare costs and healthcare associated infections. So examining the post-exposure stages of infection, you have the incubation period, prodromal stage, illness stage, and convalescent stage. So the incubation period stage is where organisms grow and multiply. You have a bunch of organisms on the body side, and they're continuing to multiply in that incubation period. Prodromal stage is when the person is most infectious, and that's at the beginning of the infectious stage. So you're multiplying, and then you're extremely infectious, and you can spread that to other people. And then you have, in that stage, their symptoms may be vague and nonspecific, such as COVID, right? You have some people who are asymptomatic and some who show symptoms. During that prodromal stage, they're most infectious, but their symptoms may be vague and nonspecific. So they can come in and they can look like they have the flu or they have pneumonia, but after doing more tests, then it is found that they may have COVID. And then the illness stage, the person will have specific signs and symptoms of a disease. And then convalescent recovery period. So that's when you're getting better. The chain of infection. So you have the etiologic agent, reservoir, portal of exit, mode of transmission, portal of entry, and susceptible hosts. Etiologic agent, microorganisms. You have the reservoir, which is the place where the microorganisms typically reside. So if we're talking about the coronavirus, that would be the etiologic agent. The microorganism, the reservoir rather, would be the lungs, the place where the microorganism typically resides. Reservoirs can be carriers where they do not show any signs of disease. You have the portal of exit, where the microorganisms leave the host through sneezing, coughing, breathing, or talking. Mode of transmission, this means the means of the microorganisms to exit the reservoir and enter a susceptible host through a portal of entry. And through that, there are 3 types of transmission: direct, immediately from person to person, such as touching, kissing, biting. And then there are indirect, which can be vehicle-borne, any substance that can immediately microorganisms to a susceptible host through a portal of entry. And then you have vector-borne, which is an animal or flying or crawling insect that can immediately transport the infectious agent, such as a mosquito bite or feces through an open wound, and airborne transmission. Portal of entry is where the microorganisms enter the body. Microorganisms usually enter the host the same way they exited the source. So if it exited the host through sneezing or coughing, typically when the susceptible host breathes in, that is their portal of entry. And then a susceptible host is anyone at risk for an infection. Any questions so far regarding the chain of infection?
Could you repeat the last one? Susceptible host?
The last one, which was the portal of entry.
So the susceptible host.
Susceptible host is anyone at risk for infection. So that is basically everyone on the planet. Everyone is at risk for an infection, no matter who they are, right? We don't walk around and we are not immune to any infection. However, we take steps to prevent infection or try to prevent infection, but that doesn't mean we won't get an infection. So it's a susceptible host is anyone at risk for infection.
Could you repeat the direct, the chain of infection, the direct and the indirect?
So direct is immediately from person to person. So this can be through touching, kissing, biting. So you are directly in contact with someone who has the disease. So if COVID example, if you are talking to someone that has COVID and you kiss that person, you can possibly get COVID. If they have the flu, you can possibly get the flu. So this is direct contact from person to person. So you would think about this one as droplet precautions of being within 3 feet of someone sneezing or coughing. That is direct contact. Indirect, it can be vehicle-borne, which is something that any substance can immediately present to a susceptible host through a portal of entry. So this can be like inanimate objects or materials such as toys, clothes, or utensils. So anything indirect will be inanimate. So you're touching a surface, or it can be like touching the stairs, anything that is not directly in contact with another person. Toys, utensils, clothes. So if you touch someone's clothes who's, let's say, contaminated with C. diff, that would be indirect. You touch the person's clothes with your bare hands unknowingly. You didn't wash your hands, and now you've put yourself at risk for an infection because you've touched an indirect object that had microorganisms on it that can transmit the disease to you. Does that make sense?
Yes. Makes a lot of
Okay.
sense. Thank you.
You're welcome. So this is just a picture showing you the etiologic agent, the reservoir, the portal of exit, mode of transmission, portal of entry, and a susceptible host. Again, etiologic agent, the microorganism, the reservoir, which is where the disease lies, the portal of exit, mode of transmission means direct, indirect, airborne, and then portal of entry. Typically the same way that it exits the reservoir is the same way that it typically enters the portal of entry, and then susceptible host. Anyone at risk for infection. So chain of infection and chain of transmission. You have the etiologic agent, as I stated, the reservoir, portal of exit. So etiologic agent, such as bacteria, viruses, fungi, and parasites. The reservoir is carriers such as human, animal, insects, or an environment. Humans, skin, nails, nail passages, mouth, intestine, anterior urethra, vagina, and then animals such as saliva and feces. And then a portal of exit, respiratory tract, GI tract, urinary tract, reproductive tract, blood, or tissue. And this is the reservoir. Portal of exit, just images of portal of exit. You have the chain of infection, which is the method and mode of transmission. Portal of entry, susceptible host. So going back, these all tied in together, but I put the picture so you can kind of correlate that with that. But method and mode of transmission, you have the direct, as I've stated, which is touching, biting, kissing, sexual intercourse, scratches or biting. Indirect, vehicle-borne, inanimate objects, material or objects, water, food, blood, serum, plasma, and then vector-borne, animals, flying or crawling insects, and airborne, which is droplet precautions, or droplet or dust. And then portal of entry, respiratory tract, GI tract, urinary tract, reproductive tract, blood or tissue. Again, portal of entry is typically the same as the portal of exit. So just keep that in mind. And then a susceptible host, infant, young children, compromised individual. So a susceptible host is any person who is at risk for infection. What do you think a compromised host is, or compromised individual?
People
The
taking
elderly.
immunodeficiency medication.
So
People who
A
have
person-
pre-existing.
person with a weak immune system.
okay, so with that in mind, are they at increased risk or are they not at increased risk?
Increase.
Increase.
Right. So a compromised host is anyone at increased risk for infection. So susceptible hosts is any person that is at risk for infection. All of us are at risk for infection. Compromised host is a person that is at increased risk for infection. So as you stated, so elderly, they're at increased risk because they're compromised. Someone that is getting chemo, someone that is immune compromised, HIV patients, you have transplant patients. All of these patients are compromised hosts and are at increased risk for infection. Direct transmission, such a cute baby. However, they can transmit it, touching, biting, kissing. Indirect, vector-borne.
Ms. Green, can you slow down just a little bit? Because you're going kind of fast and I'm trying to keep up with you and you're clicking and
What'd you miss? What did you miss?
No, just keep going, but I'm gonna hang in there. just
Just be
slow
mindful.
down just a little bit.
This is recorded, okay?
Okay.
It is
Okay.
recorded. The previous lecture is uploaded, but I'm probably going to change it out to this one. So this is recorded. If I talk too fast, which I typically do, then it is recorded for your viewing at a later date. So,
Thank you.
but I will definitely try to slow down. So airborne transmission through the air. And this is a picture of the portal of entry. And so you have all these sites that are portal of entry: conjunctival route, the ears, the eyes, the mouth, wounds, transcutaneous channel, animal bites, genital tract, all of those sites, as you see, and many more, are portals of entry. And you have,
Can like puncture skin also be part of portal of entry?
yes, definitely. So you know that if you have a puncture, that means there's a break in the skin, right? And so if there's a break in the skin, that puts you at risk for getting infection, such as I stated, if you have a staph infection, you had a break, we typically carry staph on our skin, but if there's a break in that skin, that staph can now get into the tissues and cause cellulitis. So yes, that is. Any other questions? If you're talking, Eleanor, okay,
have a question, Ms. Green?
All right, yeah, the same thing goes as, if you have an IV site and you have that puncture there, would that be acceptable for infection too, right?
Absolutely. So that's called phlebitis. And so if you have an infection site, if you have that, anything that there's a break in the skin contact. So if you have an IV, there's a break in the skin. And so, which is why it's important that IVs are changed. The sites are changed regularly, that you do the proper care, that it's bandaged properly, because again, there's a break in the skin. It can cause an infection.
Ms. Green, for portal of entry and portal of exit, you say they basically can be the same. A lot of times, if it's an exit through the nose from the mouth, it's going to enter through the mouth. When looking at a question, how is it that you can differentiate between the two?
So the question would typically ask, what is the portal of exit or what is the portal of entry? So if you look at this one, the portal of entry, respiratory tract, GI tract, urinary tract, reproductive tract. If we go back to the portal of exit, same thing, right? So it's just based on how the question is asked, and that's when you have to use your critical thinking skills, right? So let's say if the question, I'm just thinking of one off the whim. So if the question says, you have an infected patient, let's say you have a patient that has a coronavirus that came in coughing and sneezing, what is the portal of exit?
Her mouth.
So the sneezing would be it?
Right. Right. And so then you say, let's say the nurse encountered this patient 3 hours ago, and now the nurse is exhibiting symptoms of fever and a cold. What was the portal of entry?
Her nose.
Right. So
Okay, I got it. Thank you.
You're welcome. Any other questions? All right. So we went through all of this. So identify the normal defenses of the body against infection. You have non-specific, and specific defenses. Anatomic and physiological barriers and inflammatory responses are non-specific defenses. Antibody-mediated and cell-mediated are specific defenses. So with non-specific defenses, you have the anatomic and physiological barriers and inflammatory responses, as I've stated. With the anatomic and physiological barriers, it's through intact skin and mucous membranes. So again, as someone asks about the IV site or if there's a puncture wound, intact skin is a normal defense against infection. But if there's a break in the skin, that puts you at risk for infection. Inflammatory, which is vascular and cellular responses, exudate production, and reparative phase. So that's how the body responds to infection. It is a defense against the infection. So you have vascular and cellular response, exudate production, and reparative phase. With the anatomic and physiological barriers, like I've stated, you have the skin and mucous membranes, and that is skin, which is intact, no breaks, as I've stated, mucous membranes through your eyes, nose, mouth, and reproductive system. So what happens if your body's trying to defend against the eyes? What would you typically see?
Your eyes will water.
Watery, maybe crust.
Ears.
Redness.
Redness.
Right. So the tearing, right? If your body's trying to protect your eyes, let's say from dust, your eyes would tear, right? That's your tear production. That's how your body defends the eyes defend your body against infection. Through the nose, what do you think happens through the nose?
Your nose would.
Your hair and boogers.
Yeah. Yes, that too. But your hairs, the hairs in the nose help to protect against that. And the mouth, what do you think with the mouth?
Saliva.
Yes.
Yeah.
And what about the reproductive system?
That makes its own. It's
pH. Urine.
pH. pH in the urine, definitely. So vaginal pH, this helps to protect the woman against any outside infections, and then urinating, because they have one system. So their best defense is through urinating.
Mm.
All right. So inflammatory response, as I stated, you have vascular and cellular response. And this is the first phase of response from an inflammatory response. This is the histamine release and vasodilation. So what may you see with histamine release and vasodilation?
Swelling.
Swelling.
Blood pressure.
What else?
Your vessel's opening?
Okay, so what would you see with that?
Heart rate could go faster.
Not necessarily with the as far as the inflammatory response. So the inflammatory response.
You're seeing the blood get faster to where it needs to go.
Okay, so what we see on the skin?
Redness and heat.
I'm sorry.
Heat, it would be warm.
Right. Redness, hyperemia, redness. Exudate production, second phase. Serous, purulent, hemorrhagic. So this is the type of drainage that you could potentially see with the exudate production. So let's just say you have someone that has an infection, or let's say you slammed your finger in the door, right? And now there's a pus or blood underneath the nail. Exudate production, which is serous, right? Blood, purulent, that's more of a pus, and hemorrhagic, sanguineous. And then reparative. This is the third phase, regeneration or granulation tissue. This is where the body just basically starts to regenerate itself and heal. Body response to infection, you have localized, and there's 5 signs. Hyper, heat, impaired loss or loss of functions or induration, pain, edema, and redness. So that's the 5 cardinal signs for localized infections. Open wounds may also include exudate, but this is the 5 cardinal signs. Hyper, heat, impaired or loss of function, induration, pain, edema, and redness. All infections start with inflammation. And like I said, signs and symptoms may be local. And then if there's systemic response, there are 5 cardinal signs as well, but they are a little different. So you have fever, increased pulse and respiratory rate, malaise, anorexia, nausea, vomiting, and lymphadenopathy. So with that being said, is this a systemic or a local infection?
The first one looks
Local.
Which one is local?
systemic.
The one on the left is local.
The one on the
Left is local.
Yes.
And the one on the right is systemic.
Yes. So the one on the left, this is a local infection, right? You see her right leg, which is perfectly fine. And then you look at her left leg and you're like, oh my God, it's red, it's swelling. She has a bandage on it. So do you think it potentially originated from that toe, the big toe? Possibly.
Yes.
Break in the skin, right? So there's a break in the skin. And now this infection has spread up the leg. Could be cellulitis, it could be staph, it could be anything that caused this infection to the local lower leg. This has not become systemic yet. However, an untreated local infection can become systemic. Does that make sense?
Yes.
All right, identify the body against the normal defenses. So you have the specific defenses, antibody-mediated defenses, cell-mediated defenses. You have active immunity and passive immunity for antibody-mediated. And then cell-mediated, you have T-cell system, helper T-cells, cytotoxic T-cells, and suppressor T-cells. With your active immunity, you can have, this is the host. So the host produces antibodies in response to natural antigens, infections, such as infections, or microorganisms or artificial antigens, such as vaccines. And as an antibody-mediated defense, it can be extracellular, which is outside the cell, and viral infections. And then passive immunity, this is where the host received natural antibodies from a nursing mother or artificial immune serum, such as the tetanus vaccine to prevent lockjaw. So when you say passive, who do you think received passive immunity?
Babies.
Baby from the mom.
Babies.
Baby
from placenta and from breastfeeding.
Yes, yes, yes. And so they are, this will be in the next slide, but they are covered with that passive immunity for 2 to 3 months after getting those antibodies from their mom. You probably haven't heard of this, but there's also something called herd immunity, right? So that means that if 80% of the world gets the COVID vaccine, since we're in COVID, the COVID vaccine, the other 20% are thought to be protected because you have that herd immunity, right? So this is thought that the disease is going to typically go away because now 80% of the world is now vaccinated against this disease, and now the other 20% are protected due to the other 80% receiving that vaccine. So cell-mediated, helper T cell, cytotoxic T cell, and suppressor T cell. So cell-mediated occurs through the T cells. On exposure, the large numbers of activated T cells are released into the lymph system. The 3 groups of T cells are helper T cells, cytotoxic, and suppressor. So with the helper T cells, this functions in the immune system. Cytotoxic, it attacks and kills microorganisms, sometimes attack and kill its own body cell. And then suppressor T cells. This can suppress helper T cells and cytotoxic T cells. What happens if cell-mediated immunity is lost?
People be susceptible to all kinds of infections.
Yes. They become defenseless against most viral, bacterial, and fungal infections. So if you don't have that cell-mediated body response, then this puts you at risk for infection. Your body's not responding, right? You don't have that helper T cell coming to the site to attack and kill. You don't have the cytotoxic to come and attack and kill. And you don't have that help suppressor T cells, because sometimes if the body is making too many cytokine T cells, then you may need that suppressor T cell to suppress the cytokines. So. And then a quick quiz. You are caring for a patient who underwent surgery 48 hours ago. On physical assessment, you notice that the wound looks red and swollen. The patient's white blood cells are elevated. You should A, start antibiotics, notify the physician, document the findings and reassess in 2 hours, or place the patient on isolation precaution.
B, notifying.
Anybody thinks it's something else?
Start antibiotics.
Start antibiotics? Why?
Well, I'm thinking if they post-op, they should the doctor would already order the antibiotics. So I'm gonna document and reassess in 2 hours because they just came out of surgery.
Right. So you would do that if you have an order, right? But based on the question, we don't want to assume that that's what we have. So when you're taking your test questions, you look at this question for face value. You are caring for a patient who underwent surgery 48 hours ago. On physical assessment, you notice that the wound looks red and swollen. You examine the patient, the wound looks red and swollen, right? You're thinking that there's an infection. The white blood cell count, when you reviewed the labs, they were elevated. You should start antibiotics. One, you cannot start antibiotics. You can administer them if there's an order, but you can't start antibiotics. Document the findings and reassess in 2 hours. You would definitely do that, right? Because we want to make sure that whatever we do, we reassess. That is our job. That is our goal, to always reassess. So if we implement a change, such as starting an antibiotic, we will reassess that patient, right? But we can't start the antibiotic without notifying the physician first and then getting the order to start antibiotics. And then place the patient in isolation precaution. There is no reason to unless this is an infection that has been deemed as something that is contact, droplet, or
Miss-
airborne.
Ms. Green, I have a
Make sense?
question.
So what's the rant? Notify the
They-
physician.
B, notify the physician.
Do you have to have an order to place a patient on isolation precautions?
Yes, yes. So you would notify the doctor because you ultimately don't know, right, if that patient has staph versus this versus that, or contact versus airborne versus droplet. So you definitely have to have an order to place the patient on isolation precaution.
So Ms. Green, I have another question. If you had told them that the order was placed and then they said select all that apply, would it be B, C, and D?
So if you say select all that apply, you would notify the physician and then C. So it would be B and C unless the doctor wrote an order to place the patient in isolation.
Okay.
But if there's no order, then you would do B and C. Notify the physician and document the findings and reassess in 2 hours. Because again, you have to have an order for isolation precautions and you have to have an order. Unless the order said to start antibiotics and then place it in an isolation precaution. But because we are looking at this test question at face value, it is only B and C as a select all that apply.
Makes sense now since you broke it down.
If you're doing a select all that apply, is it true and can be done, right? You notify the physician and then you document and reassess. These are both true that you can do that and it can be done, but you can start antibiotics, but can it be, is it true? It's true that you can start antibiotics, but can you do it without an order? No. And then can you place the patient on isolation precaution? Yes, but can you do it without an order? No.
This would also go back to like SBAR, right? Where you would like evaluate everything, call the physician, and
So Danielle, what would be your SBAR? Because Mr. Keller is on it. Mr. Keller chime in when she does her SBAR.
you put me on the
Danielle.
spot, y'all.
I know.
Symptoms, background, assessment, and result recommendation.
So what would be your SBAR if you were calling the doctor for this patient?
The elevated white blood cell.
Okay, so if you're gonna call the doctor, you're gonna say, what is the situation? I have a patient who underwent surgery 48 hours ago, and now his the wound looks red and swollen.
Would it be recommendation because you will want to start the patient on antibiotics?
And that could be your recommendation, start antibiotics. Doctor, can we get an order to start antibiotics?
And you have your assessment where you notice that the wound looks red and swollen.
Yes, yes, yes. Mr. Kelly, anything else we're missing for the SBAR? He may have stepped out. All right, so we'll take, what time is it? 9:13. We will take a 10-minute break, come back at 9:23. Any other questions before we take a break?
Do you have more questions like this?
I think maybe 1 or 2 more, but I can put some in the discussion board, and that way that can help you if you need like questions like this.
Yeah, we need to practice.
That'd be great.
I have a question. When you was talking about the T cells, I know that I had learned when someone had like HIV, is it HIV or the actual AIDS virus, that's when their T cells deplete, and that's what causes the other infections, like they get pneumonia and things like that, that causes the virus.
Yeah, so it's not, it doesn't cause the virus, but it causes more risk for infection, right? So are they susceptible or are they a compromised host?
Okay. Okay.
So that was a question for you, Luanza.
Oh, that's a question. They're compromised because they're what I want to say. I can't get the word. I'm on the spot. They're compromising because their immune system is weakened due to the virus.
Exactly. And so if their T cells are suppressed, what do T cells do? Help to protect the body against infection, right? So the T cell, this is a normal defense against the body's infection. But if your T cells are suppressed, then now you are compromised host and puts you at risk for catching those, as they call it in AIDS patients, opportunistic infections. But that's at a later date and a higher level where you'll go over all those opportunistic infections.
Okay, thank you.
All right, you're
I have
welcome.
a question.
I have a question.
Um,
It's about the quick quiz question that we had. So if it was to select all that apply, the correct answers would be B and C because you
Jeremiah, you
can't,
missed that conversation, huh? Because we talked about that. You missed that
No,
conversation.
I was listening, but I kind of blanked out.
Okay.
But I heard I didn't hear the final answer. I heard that you said you can't obviously start the antibiotics without the approval, and you can't put them on isolation precautions. But would they still be true?
So these are true, but can it be done?
No.
Right.
Not without the approval of the physician.
Exactly. Right. So it will only be B and C.
Okay.
Any other questions before we take a break?
Okay.
But looking at this one, it's
I
only
have a
B, right?
question, please.
Who's that, Tara?
Yeah. This is only B though. This question that you have right here, right?
It's not a select all that applies. So the answer is B because this is the best answer that you can do. Yes, you will document, but if you don't document, if you don't notify the physician, now you're delaying care. So you have to notify the physician, and then he may potentially give you orders to start antibiotics and or put the patient in isolation. And then you are still going to document and reassess. But the best answer is to notify the physician of your findings because we're thinking this is an infection. And if they're not on antibiotics, then he may want to start some, he may want to monitor it, he may want us to do other things. But we don't know that until we do the SBAR with the physician.
All right, thank you.
You're welcome.
Okay, now I have a question. Whenever you were talking about the antibody mediated defenses, under active, you had stuff like vaccines, but then under passive, there was the tetanus vaccine. Why is the tetanus vaccine passive and not active?
So the active vaccine, tetanus can be active and passive. It just depends on how they're getting it. I'll have to look into it more in detail to see why it's both active and passive immunity, but you can have both because you as if I'm the mother and I'm getting the tetanus vaccine, I have active immunity against that, but also passive immunity. So I'm going to look that up and put that in. Let me put a note in that to double check.
I can tell you the answer if you'd like.
Sure, David, but I'm going to double check. But sure, go ahead, David.
Okay, the difference between active and passive. Active is you're creating it. Passive is you're getting immunoglobulins that were created by somebody else or something else that cover and help you get rid of the infection. So tetanus is sometimes immunoglobulins. It's just active is you're creating a defense.
Right.
Okay.
So does that answer your question? But I'm going to go in to tell you more about that. David Cole, what do you do for a living?
I'm an IT director.
IT. You studied ahead?
No, I used to work in flow cytometry.
Flow cytometry. Oh, okay. That's some good stuff. All right. Any other questions? I'm going to put that in the chat. Who was it that asked that question? So I can direct.
That was me.
Brittany. Okay. All right. I will address it in the chat for you and give you a response after this.
Okay, thanks.
You're welcome.
Ms. Green, I don't have a question, but I wanted to see the non-specific inflammatory response again, please.
All right, so this will be recorded, y'all. So if you did miss this, it definitely will be, you said non-specific inflammatory, correct?
Yes.
All right, at 9:20, which is about 1 more minute, we're going to take a break to 9:30, and then I will get back on and go through the rest of this.
Thank you.
You're welcome. So if no other questions, we can take a break here, be back at 9:30, and we will finish.
Sounds good.
Hey, Mr. Keller? Are you there?
I am.
Okay, I just had a question. I was having issues with my computer and I think I logged in past the 15-minute mark. So I was wondering if I was marked tardy or not.
What team are you on?
I'm team 5.
So you need to check with Miss Strength or Miss Green.
Okay.
What number are you, love?
I'm team 5.
Okay, I'm not, I have the 32 through 38. It must be another faculty member on your team, love. Let me see.
No, she's a Miss Strength. She's in 336.
Yeah.
Oh, okay. And what's your name, baby?
Amanda Domain.
Okay. Okay. I will note it. Thank you.
Thank you.
No problem.
So are we not signing in on through the link that Ms. Dufresne was sending us?
That's team 1.
Yes.
So talk to team 1 people.
I'm doing it just to cover all bases.
I don't have the link though.
Wait, listen up. We're not going to talk about attendance. So if you got an attendance question, speak to the team faculty on your team to see what they want, okay? So just talk to someone on team 1. If you're on team 5, talk to faculty on team 5. Team 2, you come to me, okay?
Yeah. I'm on team 5. Miss Strength is on team 5.
Right.
Team 1, I'm not sure who your instructor is.
Well, no, I mean, Ms. Strength, I went over our list before, right when we started class. I gave them all the faculty members. So,
okay.
So just get in touch with your faculty on each team, since we have 3 teams here, and they will clarify what they are requiring you to do. Okay.
All right, y'all. So it's 9:30, and to address Brittany's question, so I don't have the other concept book to review, but I did pull up an article, right? Because we do evidence-based articles, and I will put this in the discussion, link this in the infection discussion or under the infection where the SLO is. So that way you can read this article because it's very good information. And so it basically talks about the active and passive immunity for tetanus, vaccines. But the thing is, tetanus can be active or passive depending on how it's made. So you have the active immunity, which I forget his name that said it, but this refers to the process of exposing the body to an antigen to generate an adaptive immune response. So basically your body wants to respond. So if you get, let's say, the flu vaccine, your body wants to respond to that. Versus passive immunity refers to the process of providing immunoglobulin antibodies to protect against infection. It gives immediate but short-lived protection, several weeks to 3 or 4 months at most. Passive immunity, usually classified as natural or acquired. And this is a transfer of maternal tetanus antibodies, as we stated, across the placenta, provides natural passive immunity for the newborn baby for several weeks to months until such antibodies is degraded and lost. In contrast, acquired passive immunity refers to the process of obtaining serum from the immune individuals, pulling this, concentrating the immunoglobulin fraction, and then injecting it to protect a susceptible person. So I will link this article in under infection so you can read that. It's a really good article. I don't have the book to reference the information in the book just yet because I have the wrong concept book. The other one I let another instructor borrow it, so I have to get that back from her. But I will link this article in there, and then when I can reference the book, if there is something more detailed, then I will do that. But always do evidence-based articles when you are looking for information to back up what you need to know. Does that help, Brittany? Probably not. I may have talked too fast, but I will link that article. So
No, it helps. Thank you.
okay, and I will link that in the infection so you can read that as well. All right, so the CDC guidelines has standard and transmission-based precautions and the use of appropriate PPE, personal protective equipment. Okay, are we not doing this? Why is my slides not working? Oh, there we go. So the Centers for Disease Control and Prevention focuses on infectious diseases, foodborne pathogens, environmental health, occupational safety and health promotion and injury prevention, non-infectious diseases such as obesity and diabetes. And this is a National Public Institute. It is located in United States. It is a United States federal agency under the Department of Health and Human Services, and it is headquartered in Atlanta, Georgia. So Mr. Silas, when he lectures, he talks about how beautiful the CDC is, how you can take a tour of it. I've never been, so I cannot vouch for that. But if you want more information on how to go about seeing the CDC, you can always email Mr. Salas and ask him, because I think he's been there and he talks about how nice it is and how great tour of the CDC. So if you're interested in that, feel free. So there's tiers to this. Tier 1 is a precaution, also known as standard precautions. This is the most important and should be used with all patients. Tier 2 precautions are expanded precautions and are specific based on medical diagnosis. Different precautions will be used for different diseases depending on how each disease is transmitted. These precautions include airborne, droplet, and contact. So you have the standard precautions, transmission-based precaution, and the PPE. With your standard precautions, you have universal precautions. This is applicable to all hospital patients. So anyone in the hospital, you use universal standard precautions. That means that everybody gets the same treatment. And then with standard precautions, you have the blood, all body fluids and secretions, non-intact skin, and sweat does not apply to this. So if a person is sweaty, yeah, you may not want to touch them, but this does not fall under the line of standard precautions. So it is blood, all body fluids, all secretions, and non-intact skin. Again, sweat does not fall under the line of standard precautions. I would wear gloves if someone was sweating profusely. I just would not want to touch their skin, but that is just me. You don't have to wear gloves for sweat. And then standard precautions reduce the transmission, reduce the risk or transmission of microorganisms from recognized and unrecognized sources. So hand hygiene, what is the #1 way to prevent infection? Hand washing, right? We wash our hands before and after entering a patient's room. We wash our hands before and after doing the procedure. We wash our hands after using the restroom. We wash our hands before and after cooking. Hand washing, the #1 way to prevent infection. You wear clean gloves, especially if you are coming into contact with a person's body fluids or blood or anything that is soiled, mess, and or goggles or face shield. Clean non-sterile gown, disposing of soiled items properly, handle soiled linen as little as possible, and follow agency protocol regarding sharps. So sharps should always go in a sharp container. I think everyone has gone through the patient safety where they were, I think, needles at the bedside. That should never happen. Every single sharp that you use, needle, should go in a puncture-resistant container. So standard precaution is the use of hand hygiene before and after all patient contact, the use of proper PPE, such as gloves, surgical masks, protective eyewear, gowns, such as fluid-resistant gowns, disposal of all sharps and puncture-resistant containers. Do not recap, break, bend needles after use. That is definitely a no-no, and you do not want to do that. Dispose of infected waste as per agency policy, such as the biohazard red bag. And that red bag is for extremely soiled items. So if it is a bandage that has maybe scant blood, that can go in the regular trash, versus if it was a bandage that had profuse drainage on it that was dripping, that will go into the red biohazard bag. But if it is just a little drainage of blood on it, that can go in the regular trash. Disposal of other waste, unsoiled linens, equipment per agency policy. Use of protective mouthpiece for CPR. The new guidelines for CPR, American Heart Association, you do not have to do mouth to mouth. It is not required unless you want to. And then transport specimens of blood and body fluids in appropriate containers with lid secured. And then work restrictions if nurse has communicable illness. So the transmission-based precautions, we have airborne, contact, and droplet. So airborne, this is things like measles, varicella, tuberculosis. With droplet, this is things such as diphtheria, pertussis, or DTaP, mumps, pneumonia. And then contact, MRSA, C. diff, vancomycin-resistant enterococcus. So if you have someone that is on contact precautions, they will have this sign on their door, contact precautions. Everyone must clean their hands, including before entering and when leaving the room. So typically you would use some hand sanitizer to enter the room, wash your hands when you get in the room, put on clean gloves, and then proceed to do what you need to do. You also will want to wear a gown, and then use disposable stethoscopes if the facility has it. If they do not, then you want to make sure that your stethoscope is wiped down when you come out of the room, unless they have the cavity wipes inside of the room. But if not, be sure to put on gloves and wipe down your stethoscope when you are out of the room. Airborne precautions, this will be on the door for anyone that has airborne precautions. Clean their hands, including before entering and when leaving the room. Put on a fit-tested N95 or higher level respirator before room entry. Remove the respirator after exiting the room and closing the door, and then the door must remain closed at all times. So this patient that is on airborne precautions will have the sign on the door. You will wear the N95 that you have been fitted for. So I know a lot of people are wearing those white N95 masks now during COVID, but those are not fitted. So that doesn't give you the most protection. The true N95 mask is where you put on a hood, and then you have to wear a mask, and then they put the sucrose in, pump that into the hood, and then you have to turn your head from side to side to see if you can taste it. If you taste the sucrose when they insert it into the hood, that means that that mask is not fitted properly, and then you would either have to go up a size or down a size. So if you lose weight, you gain weight, you can't have facial hair when you're fitted for this test, because this is truly going to be fitted to your face. And this helps to protect you against airborne precautions. And this is the only N95 mask that protects you against airborne precautions, only if you are fitted. If it is the ones that you buy at the store, you are not fitted for that mask. This does not give you 100% protection against any airborne precaution. And also with airborne precautions, the air in the room is recirculated in that room only. It is not circulated through the hospital. It is not circulated through the nursing home, or wherever it is. They may have a generator, or it's like a air condenser that recirculates the air in that room, so that way it's not diffused throughout the hospital. And droplet precautions, you want to, again, wash your hands, make sure that your eyes, nose, and mouth are fully covered, and then remove the face protection before exiting the room. So droplet precautions are within 3 feet of someone. If you're 6 feet, 9 feet, 10 feet away, it is thought that you will not get this disease, because droplets drop off after 3 feet. You will not get the infection. So PPE standard guidelines. What's the standard guideline for donning PPE? Anybody want to read that? How we're going to don PPE?
Wash your hands.
You're gonna
put your gown on, your N95 goggles, and your sterile gloves. Not the sterile gloves, just gloves again.
Yes.
Or your gloves.
Yes, wash your hands, apply a gown, apply face mask, apply eye mask protection, and then apply gloves. This is a proper way to don PPE. So if you are going into a room that you have to put on PPE and apply all of this, you will wash your hands, put your gown on, put your face mask on, put your protective eyewear on, and then apply your gloves. If you are doffing PPE, you want to first, anyone want to read that?
Doff your gloves, take off your mask, take off your gown, exit the room, then take off your face mask and wash your hands.
Right, so take off your gloves, take off your goggles, take off your gown, exit the room, take off your face mask, and then wash your hands. So there's a variety of ways to safely remove PPE without contaminating your clothes, skin, or mucous membranes without potentially infectious materials. So this is the example of how you would do that. And the CDC the paper that I put onto Canvas, it tells you 2 different ways that you can doff PPE. We are following the first one. So it is testable material. If you should see that, you may want to focus on the first one and not the second one, because we are going to focus on the first one. Again, there's 2 ways to remove PPE, but we're going to focus on the first one. Factors that increase.
I'm sorry, can you re-show the first one?
This is it. This is the way.
Okay. Okay.
Yeah, and the CDC guidelines, when you look at the paper on the printout on Canvas, it will tell you once you're reading over it that there are 2 different ways. This is a proper way: gloves, goggles, gown, exit the room, mask, and then wash your hands. Factors that increase susceptibility to infection: age, hereditary, stress level, nutritional status, current medical therapy, and any pre-existing conditions. So this all increases a person's susceptibility to an infection. Age, an elderly person; hereditary, if I have a family history of sickle cell; stress level, right? If I'm stressed and I'm not eating, or if I'm too stressed, or now I'm causing high blood pressure, I may stroke. Nutritional status, again, stress causes some people to eat more, stress causes some people to eat less. If I am not eating, then that means my body is weakened and I can be more at increased risk for infection. Current medical therapy, if I am getting chemo, if I am getting immunosuppressive drugs, or any pre-existing conditions such as diabetes, right? Diabetes puts a lot of people at risk for infection. And there are several other pre-existing conditions that can also put you at risk for infection. So which patient is most at risk for infection? The 30-year-old with asthma, a healthy 2-month-old whose mother smoke and have not had his 2-month-old vaccines, 59-year-old with diabetes, or an 80-year-old with a history of diabetes and is on dialysis.
80-year-old.
80-year-old.
The 80-year-old.
Yes, yes.
80-year-old.
Right. Right. They're 80, they have a pre-existing condition, and they're on dialysis, which means that the kidneys are not working. The 30-year-old with asthma, they're okay. A healthy 2-month, why is a healthy 2-month-old not at most risk for infection?
Because they are covered at 2 months. Their immune system covers them about 2 months.
With what?
They
have passive immunity.
Immunity from the mother.
Passive or active? I'm sorry.
No, it's passive immunity.
Yes, yes. And the 59-year-old with diabetes, yes, this person may be at risk for infection. However, you have someone that is most at risk for infection, 80, diabetes, and on dialysis.
So I have a question. If you took out the history of diabetes on the 80-year-old and it was just the natural factor that they were older, would you still put the 80-year-old or would you pick the 59-year-old?
I will put the 59-year-old with diabetes. Why? They have 2 things working against them now, right? They're 59 and they have a history of diabetes. Yes, you're 80, but that doesn't mean that you will get an infection. If you're just a healthy 80-year-old, right? I'm not the most at risk for infection. I don't have any history of diabetes. I'm not on dialysis. My kidneys are working fine. All of my organs are okay. But if I'm 59 and I have diabetes, let's just say for this purpose, it's uncontrolled diabetes, right? So now your blood sugars are extremely high, your kidney function may be declining, right? Diabetes affects every organ in the body. So that is putting everything at risk, right? It affects your vessels, it affects your eyes, your heart, your kidneys, every single thing. So this person is at risk for infection over the 80-year-old because the 80-year-old would not have any diseases or comorbidities that would increase their chances of infection.
Thank you.
You're welcome. Any other questions? Nope. All right. So patients most at risk for infection, infants, young children, and compromised individuals. And we've talked about that one. As we've stated, newborns and older adults have reduced defense against infection. Newborns are only passively protected for 2 to 3 months after being born. And then as adults get older, their immune response weakens. Oh, thought somebody said something.
Excuse me. So the infants are protected because of the mom? They passive?
Correct. So infants, they get hepatitis B vaccine at birth, right? But you have to go, once you get into Peds, they'll go into detail about this, but they get that passive immunity initially because of the placenta from the mom, right? So they get an antibodies, and then if they're breastfed, and then they get all of this passive immunity while they're baking per se, while they're growing in the stomach, they get all of this passive immunity from the mom, antibodies and everything that they need to survive and potentially not get any infection for the first 2 to 3 months. Technically, the first immunizations do not start until 2 months of life. So for those first 2 months, they need to be protected against infection. And that's where the passive immunity comes in.
Okay, thank you.
You're welcome.
So they're protected with passive immunity the first 2 months.
Yes. 2 to 3 months passive immunity protects the infant.
So Ms. Green,
After that-
oh, I'm sorry. Go ahead. Finish.
Go ahead.
No, I was going to ask, after that 2-month period, being as though, let's say that the infant is breastfed, shouldn't that extend that period of that is them actually being protected from the infection or from the infection?
Right. So that if they're breastfed, they do still get that passive immunity, the antibodies. However, they should also get active immunity from if the mom opts in to get the vaccines at 2 months, right? So at 2 months, when you get into Peds, they'll go into all the different vaccines that they start to get. So they get them at 2, 4, 6 months, and then they go on and so forth. So they start to get their active immunity as well. So medical asepsis and surgical asepsis. Asepsis is the freedom from disease-causing microorganisms or germs. Aseptic technique is used to decrease the possibility of transferring microorganisms from one place to another. Medical asepsis is used to limit the growth and transmission of microorganisms. Objects can be clean, little germs as possible, or dirty, soiled, or contaminated. Surgical asepsis can be thought of as sterile technique. This is used to keep the environment free of all microorganisms. This is used for all procedures that need to be used sterile. So medical asepsis, you have, let's say you have a leg wound. Do you think that is a sterile dressing change or just a dressing change?
Sterile.
Dressing change.
Oh, sterile. So the leg, do you think that will be sterile or surgical or medical? Because this is basically medical, right? So medical does not mean free from all microorganisms. Medical basically means that we want little germs as possible. We'll try to keep it as clean as possible, but this is not the environment without any microorganisms at all. Medical asepsis, if I have a leg wound, more than likely this is probably a medical asepsis where I'm just doing a regular dressing change. I do not have to wear any protective equipment, or I do not have to use a sterile dressing change to change that wound. Versus surgical asepsis, this is a sterile dressing change, right? If we've gone over, you've done your sterile dressing change check off, that is a surgical asepsis. We want to keep that wound, let's say it's an abdominal wound that's open, right? We want to keep that wound as free as from infection as possible. Or for instance, I worked on an LVAD unit. This is a congestive heart failure where patients were in heart failure, and LVAD is a left ventricular assistive device. And so this device goes into the heart, directly into the left ventricle, and out the stomach. And this device is keeping the heart to pump. So these heart failure patients, if they don't have this LVAD, which is lifelong until they get a transplant, if they don't have this LVAD, now this puts them at risk for dying because they can't survive. Their heart is in heart failure. Their EF, you'll get this later on, but their EF ejection fraction, or what the heart is putting out, is less than 10%, 5%. And so they don't have enough oxygen to get, or blood to get to the organs that they need. So the LVAD is placed to help pump the heart. Well, when they get this LVAD, you have, again, the entry site is into the left ventricle of the heart, and the exit site is through the stomach. Do you think this is a medical or surgical asepsis?
Surgical.
Surgical.
Exactly. We want to keep that patient free from all microorganisms as possible, because if we were to infect this patient with a dirty or non-clean or medical asepsis dressing change, now this patient is at risk for infection, and the infection is going straight to the patient's heart. The heart already is not working well, and so more than likely, if the heart gets infected, they will die from that. So when we had to do dressing changes, we put a sign on the door that said dressing changes in progress. I had to gown up, basically don all PPE, and then the patient had to wear a mask and turn their head. And then the table was white, and we did the entire procedure was sterile. So again, just make sure you know medical asepsis versus surgical asepsis. Medical, this is not free from all microorganisms, but you want to keep it as little as possible microorganisms. And then surgical asepsis is free from all microorganisms. So surgery, when doctors go to surgery or anyone goes to surgery, right, they have to scrub for like 2 to 3 minutes. My baby was in the NICU. I had to scrub for 2 or 3 minutes before I even walked into the NICU to see the baby, right? And then they do that every single time. Doesn't matter if you've gone to the NICU 3 or 4 times, you have to do it every single time you go into the NICU. And same, so we want to keep that surgical asepsis. Why? Because those patients, babies that are in the NICU, they are compromised, increased for infection.
Ms. Green, has there ever been a situation where there's been an order for a medical asepsis, a surgical asepsis, and you walked in and you saw it was a medical asepsis?
Personally have not seen that. If any one of the other instructors want to comment and say that they've seen that, if that does happen, that means that the nurse did not read the orders and follow the proper protocol, right? So then that goes into Ms. Chair's legal. Now, if something happens to this patient and they're infected because you didn't follow the orders, now you can be sued. So this all goes into the legal, right? And we want to make sure that we are reviewing doctor's orders. So when you come onto your shift, you have to make sure that you're looking at the doctor's orders, getting a good report, so that way you do follow the proper protocol. But if you do a medical asepsis dressing change versus a surgical asepsis, and it required a surgical, and this patient gets an infection from you not doing the right dressing change, you can be sued for that. So I have not personally seen that. I don't know if any of the other instructors have, but if it happens, you can be sued and you could potentially lose your license. Again, you can get them back, but that'll go into Ms. Chair's lecture with legal. So she's gonna talk to y'all about following orders and reading orders and all of that stuff. But I would definitely make sure as a nurse that you follow the orders as it is. Don't listen to another nurse and say, oh, it's okay to do, the dressing change like this because we've been doing it. But that's not what the order say. So I wouldn't do it unless the order said, okay to do a regular dressing change. But if it says sterile, then you have to do a sterile dressing change.
I have a question, Ms. Green. I'm a little confused of when you say dressing change, I automatically assume sterile. So I wanted to know like an example of a medical dressing change.
So dressing changes don't have to be sterile. What would make a dressing change sterile?
Well, I'm thinking of a wound, like anything that, like in your notes, you have like lungs, the bladder, the chest cavity. So anything that can affect the major organs, but you also have punctures through a skin, which is what I associate with a wound. So if they have a leg wound, they might have like an opening there. So why would I go do a medical dressing change versus a surgical dressing change?
Because that leg wound is not in a body cavity that particularly will cause harm per se, right? So if the leg, we're thinking this is a localized site, but if it's in the abdomen or chest, let's say if they just had open heart surgery.
Okay.
And if they have some, let's say some area that could potentially infect the heart or stomach, then that's an open body cavity. The leg is, we're thinking localized. It does not have to be sterile. This site ideally would not cause any harm to the patient. It does not have to be sterile. This is an open wound and it's just going to be changed regularly. That's it.
Okay. Would that go be the same with the upper extremities? Because like the arms are kind of closer to the chest. So would you still do like a medical asepsis, like dressing change on the arms as well?
Yes.
Okay.
Yes. Unless there's an order for some reason, let's say if they have a central line or a PICC line, that would be a surgical asepsis, right? This is an open wound that's going to the heart. The PICC line is the IV, but it's going closer to the heart, not actually in the heart, but that one is going closer to the, so that is a surgical. You have to have a sterile dressing change for a PICC line. It's an open wound or open IV that's going close to the heart. So that is a dressing change that is sterile. A IV is not sterile dressing change. Do you see the difference? That's peripheral. Peripheral IV, it's not going near the heart, it's not going close to the heart, it's localized in one area, such as if it's on, let's say, the forearm, you have a cut on the forearm with sutures, that is localized to that area. The chances of that infection or wound getting infected and going to the heart are slimmer. It can happen. Now, don't get it twisted. It can happen, but if you are doing the proper dressing change and you're doing the dressing change daily, then that site should not get infected and it should not spread. If it does get infected, it should be localized, right? If it is not treated, then it becomes systemic. Make sense?
Yes, thank you.
You're welcome.
Okay, so what makes your sacrum or your buttocks area a sterile dressing change? Because it's a gaping wound?
I have not had to do any sterile sacral dressing changes. So unless this wound was tunneling and it was going like, I would say tunneling further into a deeper tissue cavity, I would have to look into it because I've not seen any sacral wounds as a sterile dressing change. So if it is a sterile dressing change, then it has to be some type of tunneling that's going into the body cavity, an opening, right? It's not just in the sacrum. There has to be an opening that's going deeper into the body cavity. If you're doing a packing, right? Because the wound is deep, you're doing a packing, that is sterile. So if you have to pack that tunneling wound, because again, this is going inside the body cavity. So we have to pack that with sterile gauze or sterile iodoform or whatever the doctors choose to use to pack it. But if it is just a topical sacral wound, you should not need to do sterile. But again, if it has some type of tunneling where you have to pack, then you would use sterile.
So Ms. Green, if it goes deep, that's sterile. If it's just like not too deep, it's medical.
It depends, right? Because if you have a deep wound, then they should not be that deep where you should have to pack the entire wound. If it is that deep, then they probably would have a wound vet or staples or sutures or something like that, right? So you usually doesn't see, but tunneling is different from deep. So tunneling, you have a hole somewhere that's being tunneled a little bit deeper into the tissue.
Ms. Green, it's not
Hey,
a call
just a
anyways, though,
second.
right?
Let me
So, like-
jump in here for a minute. I think what y'all need to understand is we follow orders as far as wound dressing. So the doctor has to write the orders. Wound care has to write the orders. So we don't look at a particular wound, if it's a sacral wound or a surgical wound or whatever it may be. It's a wound, and we go to, before we do any dressing change, we check orders, correct? So if doc says sterile dressing, we do a sterile dressing. If doc doesn't say sterile dressing, we don't do a sterile dressing. So we follow orders, okay? So it doesn't, it's not where the wound is or if there's tunneling and things, all of those could be sterile or they may not. So it doesn't matter. Doc gives us the orders. So does that clarify all these questions?
Yes.
Thank you, Mr. Keller.
Okay, all right, because y'all all kind of bouncing around the same thing, but it all goes back to what the physician tells us to do, right? So, so just correct, Ms. Green, is that, I'm sorry for jumping in, but
No, that's okay.
is that
Yeah,
what? we're-
absolutely. It depends on the order,
Right.
right?
So wound care gets involved, doc gets involved, nurse gets involved. So all of this type of thing. Some of y'all did wound care sterile dressings on the buttocks with the decubitus wound. That doesn't mean anything. That's just the mannequin we have. Okay. I mean, that doesn't mean that all those wounds have to be sterile dressings. So it's just the mannequins we had and the instructor used them to teach you how to do a sterile dressing, okay?
All right.
So we always check our orders. We look to see what doc has ordered, and then we go from there.
Yes. So to sum that up, check your orders. But recognize conditions that promote transmissions of healthcare associated infections, urinary tract, surgical sites, bloodstream, and pneumonia. And then with the urinary tract, you have improper catheterization techniques, contamination of closed drainage system, inadequate hand hygiene. So this is all ways that you can potentially cause a patient to have that urinary tract infection or a healthcare associated infection. Surgical site, such as inadequate hand hygiene, again, improper dressing change technique. Bloodstream, which is again, inadequate hand hygiene, improper IV fluid tubing and site care technique. And then pneumonia, which is again, an inadequate hand hygiene, improper suctioning technique. So the common denominator here is hand hygiene. They all have their particular things, but the number one common denominator here is hand washing. If you have improper hand hygiene, you are putting the patients at risk for a healthcare associated infection. And then ways to break the chain of infection and optimize infection control measures. You have the etiologic agent, which is to ensure items are clean, disinfected, or sterilized, and to educate the patient and family. You have the reservoir, which is the carrier, and you want to assist with skin and oral care, dispose of soiled items, empty containers, and cover containers. And then the portal of exit, which is from the reservoir. You want to avoid talking, coughing, or sneezing during patient care. Cover your mouth and nose when coughing or sneezing. With the mode method of transmission, you want to make sure that you are using proper hand hygiene, wearing appropriate PPE, such as gloves, gown, mask, goggles, and shields. And with the portal of entry, which is a susceptible host, you want to make sure that you use proper medical aseptic techniques, use of appropriate surgical aseptic techniques, and dispose of used equipment or items properly and single-use items per patient. And with your susceptible host, you want to make sure that you maintain intact skin and mucous membrane, ensure balanced diet, educate and encourage immunizations, stress management, and activities of daily living. So these are all ways to break the chain of infection and optimize the infection control measures. Any questions about that? So to test your knowledge, an infection marked by sudden onset of detectable symptoms, usually followed by complete or apparent recovery, such as a virus replication followed by clearance or severe public health problem. This would be an acute or chronic infection.
Acute.
Acute.
Yes. This would be an acute infection. So let's look at this really quickly. And I want y'all to listen to this and we'll talk about this. Is it playing? Oh, there it goes. Make sure y'all can hear it.
Warning, do not confuse any lightheartedness in the following video with a good attitude toward the problem at hand. The makers of this video are very serious about the prevention of hospital infections. Another busy day. Now, he goes right past. Doctor. That's the last thing. Not even in gloves. Oh, come on. That doesn't really happen, does it? If you could see what I see. MRSA, VR, Pseudomonas, etc. Your attendant isn't wearing gloves, so you're not even, right? Wait, the hand gel. Okay, yes. Oh, those microbes. MRSA, good. Nurse, you didn't clean your hands either? Oh, man. He just sent out the patient, and you put a big IV in his neck. It goes almost all the way to his heart. Please, no! Finally, that's the part I wanted to see. Clean your hands before and after every time you contact the patient or the patient's environment. If your hands are not visibly soiled and the patient doesn't have CP, use alcohol-based hand gel to kill those germs. See? Doesn't slow you down. Really, you should also clean your equipment just as often. Your patients thank you.
All right, so to wrap this up, anybody have any questions about this video? It basically shows how you can transmit germs from room to room, from patient to patient, indirectly, from inanimate objects, from the patient had a central line, as I stated before, and then they had heart surgery, right? So these are all ways that you're going to transmit, you can transmit infection. So let me just ask this, how many people clean their cell phone? Or wipe down their cell phone? Put it in the chat, because I know a lot of people are going to talk. So let me just see how many people actually do it. There's 154 people, including instructors. So everybody is saying me. Y'all
I
wipe down.
don't. I don't.
I did not do it regularly prior to Katrina. I'm about to say Katrina. Prior to COVID. But I've started to pay attention to that. This video just shows you how not wiping things down and not washing your hands, you can transmit these germs without even consciously doing it, right? Subconsciously, we just automatically, go and touch our cell phone, or open the door and then touch our cell phone, or walking through the store, getting groceries and touch our cell phone, right? So again, these are all ways that you can transmit your germs, the germs that you acquire from touching different objects to your cell phone, and then you pick up your child, or you go by your, your mom or your grandmother. So any questions about that? This is just to be mindful of the germs that we transmit, which is why, as we had a huge conversation about, you want to make sure that you are, when you're changing dressings, that you're doing the proper dressing change per doctor's order. Any questions at all?
So even if you wash your hands, wash very well before you touch any of your belongings, you still have to clean your iPhone and everything, right? It doesn't matter.
Right. So the cell phone, because as you saw in the video, it carries germs. You have germs on your hand. If you come from outside and touch your doorknob, and then most people, we're glued to our cell phones, right? I think there's studies that say we touch it however many thousand times per day. And the cell phone itself has many germs. So just washing your hands and wiping your cell phone down with bleach wipes or whatever you choose, but it's just to keep you mindful, right? This may not be a practice, you may not do it all the times, but if you do touch your cell phone, just make sure you're washing your hands before and after doing things. So the number one way to prevent infection is hand washing. And that's ultimately what this video is talking about, hand washing, right? Had they washed their hands, the germs wouldn't be on the phone that now 30 other people may touch. And now it went on their face as well. Any other questions?
So we're supposed to use the book to find the answers to the exemplars like influenza and conjunctivitis, I think.
Yes.
Okay.
You're welcome.
Miss Green, they didn't have an exemplar for thrush in the book listed, a reading for it. Am I missing something?
All right, so I'm going to go through it and put it in the information in there. There should be in your book. I will put it on the exact pages where I found it.
Okay.
And for your exemplar.
Okay, thank you.
You're welcome. Any other questions? No? Well, this is the end of your infection lecture. I hope you have learned something. If not, then refer back to this video or look at your outline. The outline has the information that you need to prepare for your exam. So you all have a good day.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am.
You're welcome.
Thank you.
To post the passive and the active too?
Yes, I'm going to put that in there as well. I'm going to put that, and I'm going to put the thrush, the page where you can find the thrush and conjunctivitis.
Great, thank you.
You're welcome.
Bye-bye.
Bye.
This is Kathy Strength. I took roll.
You took roll? Okay, Miss Strength, thank you. I think I start next week, right?
Yeah. You were going to start this week, but that's okay. No big deal.
This week? But I had to lecture this week. That's why I didn't do this week.
No problem. It's no problem. No problem.
Ms. Green, one question I have is, we'll be doing the exemplars in the book, and then, of course, they have the practice questions at the end. And then I kind of checked the back of the book to see if it had the answer, and it kind of doesn't. And I just want to make sure I'm actually doing the right thing. So is there any way, I guess maybe we could email you the answer that we think might be
put it in the discussion board so that way everyone can see it, and then I can reply to that.
So if we're just super wrong, we're super wrong in front of everyone.
I mean, so but that's a good point that you have. As a nurse, are you worried about being super wrong in front of someone or catching your mistakes?
You're right.
So you want to make sure that I have a story. When I was a new nurse, I to sum this up to make it quick, but I didn't ask the question that I need to, and I had a heart failure patient that was going to go home on a Primer Core drip. Well, I stopped the drip, And ultimately, the half-life of that is like 10 minutes or so. And so with that being said, I was about to send this patient on an hour ride without their heart medicine that was going to keep their heart.
Oh.
So that being said, luckily my preceptor caught it, and we had to keep the patient there for 4 more hours to restart the drugs, to monitor them. Thankfully, it was just a delay in that patient going home versus that patient dying. So I would not be worried about being wrong, but rather catching mistakes.
Okay, thank you.
You're welcome. I'm going to look at that, Alexandra.
Miss Green, you're gonna repost this video?
Yes, I'm going to take the other one down and repost this one today.
Okay, all right, thank you. Because I had trouble with my internet, and I got logged off for a little while.
No problem. I will post this one today.
Thank you so much.
You're welcome.
Bye now.
Bye. Nobody else? That's it? I am logging off. Stop share. Leave.